limited time.
We're ready, right? We're ready at our end. So.
Okay, awesome. Okay, so I'm going to go ahead and introduce our speakers for the morning. So good morning, everyone. Welcome to today's presentation on breast cancer. We have with us two incredible breast cancer experts, Dr. Michele Drotman and Dr. Lisa Newman, who are here to share their wealth of knowledge with all of us. And immediately following the presentation, Tanya will provide a brief Spanish overview. And like I mentioned, due to the limited time for the presentation, please write all your questions in the chat or wait to ask your questions at the end of the presentation, and we'll be sure to get to everybody. So today our presentation will be split into two 25 to 30-minute sections. So we're going to begin with Dr. Drotman. And Dr. Drotman is currently the chief of the Division of Breast Imaging. She is an associate professor of clinical radiology at Weill Cornell Medical College and an assistant attending radiologist at New York Presbyterian Hospital. Dr. Drotman's clinical expertise is in women's imaging, and she performs a wide variety of exams and procedures. So without further ado, I'm going to pass over the floor to Dr. Drotman, and feel free to take it away whenever you're ready.
Great, thank you for that kind introduction, Allegra, and thank you all for having me. Let me just share my screen. Is that showing up correctly? Okay, great. So that was a great introduction. I am Michele Drotman, and I'm a radiologist at Cornell. And today I'd like to touch on just the basics of breast imaging with you and give you a handle of what we as breast imagers do and why what we do can be so important. So breast cancer is the second most commonly diagnosed cancer among women, and it is also the second most common cause of death due to cancer, accounting for approximately 40,000 deaths in the US annually. And it is a very common entity in that 1 in 8 women in the course of their lifetime, or 12% of all women, will develop breast cancer. And here at Cornell, breast cancer is by far the most common breast cancer diagnosed in women. You can see in this time period, here are all the other cancers we diagnosed. There's many more cases, up to 8,000 in this time period. So the main risk factors for developing cancer are things that we really can't control. I mean, number one is being a woman, and number two is advancing age. Other things that put us at higher risk for developing cancer are having a history of other high-risk needle biopsies or excisional biopsies and genetic mutations. However, it's important to note that 85%, or the large majority of cancers, occur in women with no family history of breast cancer at all. And a very small percentage of cancers are linked to the common genetic mutations we hear about, the BRCA mutations, only 5 to 10%. So everyone really is at risk. So the main goals of breast imaging is to help in the diagnosis, staging, and treatment of breast cancer. And we use different imaging modalities to lead to detection of breast cancer at an early stage. Screening mammography is the only imaging modality which has consistently been found to decrease breast mortality. And that's why we do recommend that everyone undergo annual screening mammography starting at age 40 or earlier if there's a strong family history. So, there are stages of breast cancer from stage 0 to stage 4, and with increasing stage, mortality also increase. So if we can find cancer early at stage 0 or 1, there's a 99% 5-year survival rate. But when it goes to more advanced stages, this goes down as low as the 20% 5-year mortality. And the majority of our cancers detected here at Cornell are detected by screening mammography. That's why you could see the large majority are early treatable stage 0 and stage 1, sorry. And about half of our cases are detected in women under the age of 60, which emphasizes the importance of screening mammography in women in their 40s and 50s. Since 1989, hundreds of thousands of lives have been saved by the use of screening mammography and new developments in breast cancer treatment. And this graph shows that after the induction of widespread screening mammography in the late 1980s, the breast cancer death rate has decreased by more than 40%. And most societies at this point do recommend annual screening mammography beginning at age 40 and continuing as long as the patient is in good health. Remember, the goal of our program is to find as many cancers early, which are the most treatable, and to therefore save as many lives as possible. So how do you go ahead and get your imaging done? So when you make an appointment, it's important to notify the staff if you have any new symptoms or anything you've noticed a change in your breasts. If you have implants, if you're currently breastfeeding, or if you'll need special services when you're on site, such as an interpreter. There isn't much preparation for the exam, but it is recommended that you not use deodorant or talcs on the breast prior to coming in, because we can see this as an artifact on the images, and we may have to repeat the images because of that. It is important to have your prescription and your insurance information all set up. And the most important thing as imagers is we like prior exams, because long-term stability is one thing we're always looking at. So bringing prior imaging from outside institutions and reports is always important. So when you get here, you'll check in at the front desk, and we always perform patient identification, and then you'll meet a technologist who will take at least 2 pictures of each breast. And we do need to apply some gentle but firm pressure. So just touching briefly on the changes we made with the COVID pandemic. As everyone knows, in March of 2020, the World Health Organization declared coronavirus a pandemic, and shortly after, a national state of emergency was declared. In New York, we put a moratorium on elective procedures, and screening mammography was discontinued for a couple of months. And we realized many patients struggled with decision-making during this time. And there are some changes that we made with COVID. Luckily, the rates are going down, and some of these we have lifted. We're not always checking everyone's temperature when they arrive, but we have kept a lot of our precautions in place. We do socially distance patients. We have no-touch systems, and we do, we encourage social distancing. So a mammogram is performed by placing the breast in compression and getting at least 2 views of both breasts. X-ray are then used, and they are transmitted through the breast, and we see different attenuation based on the characteristics of the breast tissue. And this cartoon sums up most people's impression of getting a mammogram, and every piece of humor does have an element of truth in that we do compress the breast, and this compression is not just to make you uncomfortable. It's actually really important, because the more we compress, the less radiation is delivered to the breast, and it also increases the image contrast, meaning we can see more detail when there's more compression. So it is important. The other thing that can be uncomfortable that's equally important is positioning. We have to really pull in the breast to see all of the breast tissue, or things can be missed. And just to show you that, here's an example of, these are 4 views from a mammogram. And you can see here in the right breast, this denser area, it's more white, is a mass. And the black area is fat. And you don't see anything in the other breast. This area is easily seen, it's near the nipple. But when we pull in more, we could see this dense mass way in the back. So, positioning is very important to see everything. So breast tomosynthesis, and this is also known as 3D mammography, is a relatively new but now widely accepted way to image the breast. And it has replaced or is performed in addition to a 2D mammogram. In this kind of exam, the X-ray moves in an arc and the images are then reconstructed. And it's really been an improvement in 2D mammography in that we decreased the recall rate, meaning the need for extra pictures has been shown to be significantly reduced. And we also are finding a lot more cancers. Okay, so screening mammography is performed in asymptomatic patients, and it should begin at age 40 and continue annually. There is no upper limit cutoff age we have to stop mammography. As long as you're in good health, we do recommend it. And as I said previously, the goal is to find these cancers before there are symptoms. A diagnostic mammogram, on the other hand, is for a woman who already has some symptoms, feels a lump, notices some discharge from the nipple, notices some skin changes, or has undergone screening mammography and we found an abnormality and needs to come back for extra imaging. And when you have this exam, it usually involves extra mammographic pictures and possibly a sonogram. So breast ultrasound is a very useful test. We often use it in conjunction with mammogram, most commonly to evaluate a palpable abnormality. And what breast ultrasound can do that mammography can't always do is differentiate a cyst, a benign cyst, from a solid mass that might need a biopsy. And breast MRI is another exam that we do use to evaluate the breast. It's not limited by breast density, which is something I'll get into in a few minutes. It is a highly sensitive test to detect breast cancer. However, it is a little bit more involved in that it's a longer test. It involves going in a magnet. We do have to administer intravenous contrast. And there is a slightly higher rate of biopsies that turn out to be benign. So there are pros and cons to this exam. Any abnormality that we see on an imaging test, we can then go on and perform a needle biopsy, whether we see it with ultrasound, mammography, or MRI. And this way we avoid surgery in patients that have benign disease. And if it is malignant, we could plan surgery even better. So the main things we're looking at on mammograms are microcalcifications, masses, and distortion. And microcalcifications can be the earliest sign of breast cancer, also known as DCIS or stage 0. And this is when ideally we want to find cancer. So we do look carefully, but just so you know, calcium is extremely common in the breast and most causes of calcium are benign. And also to note, calcifications in the breast are not related to calcium that you take orally. It's not related to diet in any way. It's a totally different entity. Breast masses are commonly seen in the breast as a presentation of cancer, and we check their shape and their size. Now, masses are not always easy to see, and this is coming back to something I touched on earlier, breast density. So here you could see a dark breast with a very small mass easily seen, but breast tissue, when it's dense, this is glandular tissue, can obscure a mass. So breast density, it does vary from person to person, and increasing density is an independent risk factor for developing breast cancer. However, these two less dense tissues and these two higher are split in the population 50-50. So about half the population, normal population, has dense tissue. So it's not an abnormal finding. So as it is now, we do notify all patients if they have dense tissue. And this was started years ago by Dr. Capello, and she was a woman who noticed that she had a mammogram that was normal, and then her doctor felt a lump, and it turned out to be breast cancer that was not seen on a mammogram. And she was quoted as saying, to withhold a woman's breast density composition from her is denying her the right to make an informed decision about her breast health. Like I said, dense breasts can obscure cancers. It does affect 50% of all women, and it is an independent risk factor for developing breast cancer later in life, a 4- to 6-fold increase. It's only determined by mammography. So when you go to a physical examination, the doctor cannot tell you how dense your breast just based on how they feel. And now most states do have the dense notification bill, which means that when you get a letter with your mammogram, it will tell you if you have denser tissue. It will tell you it's harder to find cancer in your breast, that you're at increased risk of breast cancer, and you might want to consider additional screening options. And we know this can sound a bit alarming, especially something that affects so many people. So what we formed at Cornell was a consultation service. And the aim was to increase communication between the radiologist and radiology staff and our patients who might receive this letter and be alarmed, so we could go over the different options. And we were actually, we were awarded an award for this service because so many patients did use it. And during the COVID pandemic, our consultation service was used even more. We kind of expanded it outside of breast density, and we were able to keep in touch with our patients and guide them through the time when it was more difficult to get a mammogram. Luckily, that's not so much the case anymore. And as you could see, the use of our service has increased over time. So in summary, mammography does remain the standard of care for detection of early breast cancer in all women aged 40 and over. And it's the only screening modality that has proven to decrease breast cancer mortality rates. You may want to consider additional screening examinations such as ultrasound or MRI. However, these do not replace annual screening mammography. And each test does have its advantages and disadvantages. So thank you so very much for your attention, and feel free to contact me or put in questions in the chat, or you can ask them later. Thanks for your time.
About breast imaging that I think everyone could use. So the next speaker I would like to introduce is Dr. Lisa Newman. Dr. Newman is an internationally renowned surgical oncologist with a practice dedicated to breast cancer management. She currently serves as chief of the section of breast surgery at New York Presbyterian Weill Cornell Medical Center. She oversees an international breast cancer research and training program, and her primary research has focused on race/ethnicity related variation in breast cancer risk and outcome. So without further ado, I'll let Lisa Newman take the floor. Thank you again for joining us.
Thank you so much. Hopefully my slides are showing up.
Yes.
Okay, great. It's going to go to presentation mode. Thank you for that introduction. It's always such a pleasure to be able to join my amazing colleague, Dr. Drotman. So Michelle spoke to you about the importance of screening with imaging modalities. I'm going to be talking a little bit about risk factors for breast cancer, but I'm also going to talk about what happens when a breast cancer is diagnosed by one of my colleagues, such as our expert radiologists, including Dr. Drotman and her team. And towards the end of the lecture, I will also talk a little bit about breast cancer disparities and international variation in breast cancer burden. So with October being Breast Cancer Awareness Month, we frequently discuss risk factors for breast cancer, how to identify a woman who is more likely to get breast cancer compared to another woman. And increasing age is by far and away the strongest risk factor for getting breast cancer. Every year that we get older, the likelihood of being diagnosed with a breast problem increases. We do also look at family history of cancers, so whether it's breast, ovarian, colon cancer. There are several families where you will see clustering of cancers, and that can increase an individual woman's likelihood of getting breast cancer in that family. And important to remember that we have to look at both the maternal and the paternal side of the family when we evaluate these pedigrees. We talk about reproductive patterns and childbearing patterns, and in general, women that have breasts that have been exposed to multiple hormonal cycles and fewer interruptions of those hormonal or menstrual cycles in the form of multiple fewer pregnancies or late age at having their first live birth. those multiple hormonal cycles that the breast is exposed to tend to increase the risk of getting breast cancer, whereas women with multiple pregnancies tend to have a lower likelihood of getting breast cancer. And this probably to some extent explains the overall lower breast cancer burden that we see in women from many lower and middle income countries, because they tend to start having children at younger ages, and they tend to have multiple pregnancies, and that does confer some protection. Now, many women will have biopsies of the breast that turn out to be totally benign and show fibrocystic changes. And it's always good news when we see a benign result in a breast biopsy. But it's really important for women to understand the details of that benign breast biopsy, because some benign breast biopsies will show evidence of breast tissue that is overactive or breast tissue that has abnormal proliferation. And these patients with overactive breast tissue are more likely to get breast cancer in the future. So it's important for women to understand that risk to protect themselves better. And this higher risk of breast cancer might mean that they need to follow additional screening practices, or they may even want to pursue some type of a breast cancer prevention strategy. Women that have a history of the breast tissue being exposed to therapeutic doses of radiation, such as what was called the mantle radiation, which used to be offered to patients with Hodgkin's lymphoma of the chest. This breast radiation, especially if it was delivered during the adolescent years or the early adult life years, tends to increase the likelihood of getting a breast cancer 20, 30 years later. There are lifestyle issues that can affect breast cancer risk. Women that are obese, especially in the postmenopausal age ranges, have a higher risk of getting breast cancer. Women that have taken supplemental hormone replacement, and in particular combination hormone replacement therapy, this can increase breast cancer risk over several years. Excessive alcohol intake is another risk factor for getting breast cancer. And as Dr. Drotman mentioned, women that have extremely dense breast tissue on their mammogram are also at higher risk for getting breast cancer in the future. In terms of going a bit further with some of the personal risk factors, it's also important to look at the individual patient's personal cancer history. And a woman that has one breast cancer is definitely at higher risk for getting a completely new breast cancer on the other side. And so women with a personal history of breast cancer have to be monitored aggressively. The family history, as we mentioned, is important to look at on the maternal and paternal side, because we get our genes from both of our parents. And we also want to look at the extended family history. So we want to go beyond the parents and the siblings. The patterns of breast cancer in the family will also be valuable in assessing whether or not there's hereditary susceptibility or hereditary predisposition. Families where you see multiple breast cancers diagnosed, especially if those cancers were diagnosed at younger ages, a family history of a bilateral breast cancer, or a family history of a male with breast cancer, those are all going to be factors indicating that there's a likelihood of hereditary predisposition for breast cancer in the members of those pedigrees. Ashkenazi Jewish background is another risk factor for having hereditary susceptibility for breast cancer, because there are certain patterns in the BRCA1 and BRCA2 genes that are quite specific among individuals with Ashkenazi Jewish background. If we do identify a patient that appears to have hereditary predisposition for breast cancer, doing the genetic testing to try to document that hereditary predisposition can be done in a very straightforward way via collection of either a blood or a saliva specimen from which the DNA can be extracted and then analyzed. Important, however, to know that we haven't identified all of the genes and their mutations that can be associated with breast cancer risk. And so it is still possible to have a negative genetic test, even in families where there is pretty clearly some type of hereditary predisposition. Also important to bear in mind, as Dr. Drotman mentioned, that more than 3/4 of the breast cancers that we diagnose occur in women that don't have any identifiable risk factor. We do continue to ask about these risk factors, however, because women that are clearly at higher risk may want to consider enhanced screening, such as use of the MRI that Dr. Drotman mentioned, and women that are at high risk may want to consider taking special medication that can lower their risk of getting breast cancer. Some women will even opt to undergo a prevention or a risk-reducing prophylactic mastectomy surgery to reduce their risk of getting breast cancer. Now, we do always, however, encourage screening for breast cancer because it is such a prevalent disease, especially here in the United States. And the way that we can detect breast cancers at an early stage would be with self-examination or self-awareness, clinical breast examination on a regular basis by your healthcare provider, and most importantly, screening mammography. Very important to remember that screening mammography guidelines are intended for women that have a normal breast exam. As soon as a woman develops some new sign or symptom of a change in the breast exam, then that woman needs to undergo a diagnostic evaluation, regardless of when her most recent mammogram was performed. Definitely, early detection saves lives. We advocate very passionately in favor of all average risk American women undergoing screening mammography beginning at age 40 and yearly thereafter. Women that have risk factors for getting breast cancer, such as those abnormal biopsies that we discussed, or women that have hereditary predisposition, may well need to undergo their screening imaging at even younger ages, or they may need to undergo the enhanced screening. The advantages to catching breast cancer early are not only related to the life-saving advantages, but they also have additional advantages with regard to the treatment that is delivered. A woman whose breast cancer is caught early is more likely to be able to avoid a mastectomy as surgical management for that breast cancer, and she may well be able to undergo a lumpectomy. For those women who do undergo mastectomy, they are more likely to have successful breast reconstruction if the cancer was caught early. Catching a breast cancer early reduces the likelihood of needing chemotherapy, and it also reduces the likelihood of needing extensive lymph node surgery, which can have a pretty dramatic impact on subsequent quality of life. Now, we also advocate in favor of breast health self-awareness because it is true, unfortunately, that breast imaging is not perfect, and it's also not widely available on a global international basis. And unfortunately, women in many low and middle income countries do not have routine mammography services available. Because breast imaging is imperfect, we do want women to be aware of changes that should prompt medical attention, such as a new lump in the breast, a lump in the underarm area, a bloody nipple discharge, skin changes in the breast, such as redness or inflammation, swelling in the skin of the breast. If there's an eczema type of a rash in the breast skin, especially occurring in the nipple areolar skin, this is also a potential danger sign of breast cancer. Now, we don't want women to panic if they develop any of those symptoms, however, because all of those problems can also have completely benign non-cancerous causes. But it's important to get those symptoms checked out so that we do get an appropriate explanation for them. If you don't feel that you are getting adequate information regarding any breast symptom from your healthcare provider, please do feel comfortable asking more questions or seeking an additional opinion. Also important to bear in mind that there are things that we can do to lower our likelihood of getting breast cancer over the lifetime. For premenopausal women, nursing, lactating after a pregnancy will lower breast cancer risk. For women of all ages, following a healthy, balanced diet with lots of fresh fruits and vegetables, it will reduce breast cancer risk. Avoiding obesity will reduce breast cancer risk. Exercising regularly and avoiding a sedentary lifestyle is important. And minimizing alcohol intake will lower breast cancer risk. If we do notice some type of an abnormality on either the breast exam or on the breast imaging, It's very common for a breast biopsy to be necessary to sort out whether or not a dangerous problem is going on. And a breast biopsy refers to any procedure where we are extracting some piece of tissue from the breast. This can be done as a needle biopsy. Needle biopsies can either be in the form of a skinny needle biopsy or a cord needle biopsy, which extracts kind of like little spaghetti strand pieces of tissue from the breast. Or a breast biopsy can be in the form of a surgical procedure where a woman actually goes to the operating room and has an incision made on her breast to extract a small wedge of breast tissue. Punch biopsies can also be performed in the clinic as an office-based procedure where we use a little circular scalpel to extract a little piece of skin from the breast if we see an abnormal skin change on a woman's breast exam. It's critical to have some type of biopsy proof of a breast cancer diagnosis before we actually initiate treatment. This biopsy proof of breast cancer is not only important to make sure that you know that you are indeed treating a breast cancer, but you also have to characterize the type of breast cancer. We have to determine whether it's a full-blown versus a precancerous condition of the breast. And you need to characterize the personality of the cancer. And we look at specific markers called the estrogen receptor, the progesterone receptor, and HER2/neu. These biomarkers, these proteins on a breast biopsy material will determine the medical treatments that the woman will need for managing her breast cancer. Some of our needle biopsies or surgical biopsies are performed based upon what we are feeling on examining the breast, but often we rely upon our breast imaging colleagues, such as Dr. Drotman, to perform image guidance for our biopsy procedures. And image guidance can very much improve the precision of the biopsy procedure so that we know that we are extracting the best possible piece of tissue that can then make a diagnosis of whether or not a cancer is present. We do indeed, as Dr. Drotman mentioned, prefer to establish a breast cancer diagnosis through a needle biopsy, because this is going to be a more efficient way of diagnosing the cancer, has the lowest morbidity, and allows for the patient to make her treatment decisions in a much more efficient fashion. But if the needle biopsy is unsuccessful in establishing exactly what's going on with any breast problem, then a surgical biopsy may still be necessary. If we have identified a cancer as ongoing in a woman's breast, there are basically 3 principles that need to be addressed in the treatment plan for that patient. Number 1, you need to get rid of that primary area of diseased tissue in the breast. And number 2, you also need to treat the microscopic cancer cells that are usually hiding in the normal appearing breast tissue surrounding the abnormal area of cancer that was biopsied in the breast. And these first 2 principles leave us with the most basic surgical options for the breast itself, one option being mastectomy surgery with or without breast reconstruction performed by the plastic surgeon. And usually that reconstruction can be performed at the same time that the mastectomy is being performed. As an alternative to the mastectomy, patients can undergo a lumpectomy, and then we rely upon breast radiation to take care of the microscopic cancer cells hiding in the surrounding breast tissue, the breast tissue left behind after the lumpectomy was performed. The third principle of managing breast cancer is that we will usually need to do some type of a surgical procedure on the lymph nodes of the underarm, because this information regarding whether or not the cancer is hiding in the lymph nodes contributes to the staging of the cancer. And that information in turn helps us to decide on some of the medical treatments, or what we call the systemic therapies that the patient will need. Medical or systemic treatments for breast cancer are critical in optimizing breast cancer survival rates, because for any breast cancer, no matter how tiny it is when we find it, we are indeed always worried about the possibility that some of those breast cancer cells have already escaped from the breast and gotten into the bloodstream. And through the bloodstream, they can be hiding in other organs like the liver, the lungs, the bones. The microscopic breast cancer cells hiding in those other organs won't necessarily cause any symptoms, and you usually can't see them on tests like CAT scans or PET scans because they are too tiny. But those are the breast cancer cells that we actually worry about the most, because if those microscopic cancer cells hiding in other organs continue to grow, that's what can turn into metastatic breast cancer, which is a potentially life-threatening problem. The medical treatments that we have for breast cancer are wonderful at totally wiping out the microscopic cancer cells hiding in other organs, and so they prevent women from developing metastatic breast cancer. And the decisions about the medical treatments that a woman will need are going to be based upon the characteristics of the cancer and also based upon the stage of the cancer. Some medical treatments are in the form of special cancer-fighting pills. Some medical treatments are in the form of special targeted infusion medications. Other medical treatments are in the form of chemotherapy. Now I'm going to speak briefly about some of the international variation that we see in breast cancer. As shown on this slide, more affluent countries, including the United States, have a very high breast cancer burden. We are much more likely to develop breast cancer in the more affluent countries and Western countries compared to women of low and middle income countries. The breast cancer burden of women in low and middle income countries is, however, rising, and these rising incidence rates in the poorer nations is related in part to the fact that longevity is increasing in these countries. So now they are starting to see more breast cancer in their older aged women. And lower and middle income countries are starting to adopt more of the westernized life patterns, such as reproductive patterns with having children somewhat later. They are adopting many of our dietary patterns, and this is also contributing to rising breast cancer incidence in other parts of the world. In the low and middle income countries, unfortunately, there are fewer treatment advances available, and so the breast cancer mortality rates tend to be higher, and the ratio of mortality to incidence of breast cancer is also higher in these poorer countries. We also see differences in breast cancer burden among women with different racial ethnic backgrounds here within the United States. And this slide is demonstrating that breast cancer incidence and mortality rates are variable in the United States based upon a woman's racial ethnic background. The most stark differences in breast cancer burden are seen between Black women and white women. And as shown by the curves on the left of this slide, breast cancer incidence rates have typically been lower for Black women compared to white women, but the incidence of breast cancer has been rising in Black women, and now those rates are actually comparable. We have, as shown by these curves on the right of this slide, been seeing some declines in breast cancer death rates, breast cancer mortality rates. However, breast cancer mortality rates are substantially higher for Black women, and the mortality rates from breast cancer are 40% higher in Black women compared to white women in the United States. Now, much of the advanced mortality rate that we see for breast cancer in Black women is related to the fact that Black women are more likely to be diagnosed with a bulkier node-positive cancer, and this more advanced stage distribution of breast cancer in Black women is largely attributed to higher poverty rates and higher rates of unemployment in Black women, which of course creates disparities in access to screening and in access to other early detection methods. And we see higher rates of inadequate breast cancer treatment among African American women. We also, however, see other patterns that characterize the breast cancer burden of Black women that really can't be easily ascribed to socioeconomics. For example, Black women tend to be younger when we are diagnosed with breast cancers compared to white American women. We tend to be diagnosed with the biologically more aggressive cancers, such as estrogen receptor negative and what we call triple negative breast cancers. We have a higher incidence of primary inflammatory breast cancer, which is another biologically aggressive form of the disease. And the incidence of male breast cancer is also higher in the African American community. So we do also have a lot of research that continues to need to be performed in understanding breast cancer disparities related to tumor biology and genetics. The triple negative breast cancers that I mentioned briefly are inherently more aggressive breast cancers, and we call these tumors triple negative because they are negative for those three biomarkers: estrogen receptor, progesterone receptor, and HER2/neu. The triple negative breast cancers are twice as common in Black women compared to white women, and they are also more common in women that have BRCA1 mutations. Triple negative breast cancers are more common in Black women regardless of the age at diagnosis, and also regardless of the stage at breast cancer diagnosis. Our Weill Cornell-based international breast cancer research program has been studying the breast cancers of women here in the United States and also in women of Africa. And we've identified an interesting pattern where we see extremely high frequency of triple negative breast cancers among women in Ghana, which is located on the western sub-Saharan coast of Africa, where more than half of those tumors are triple negative, but only about 15% of the breast cancers from women in East Africa, including Ethiopia, are triple negative. And the frequency of triple negative breast cancer among African American women is intermediate between what we see in Ghanaian women and what we see in white American women. So we call these patterns an example of oncologic anthropology, because the transatlantic slave trade from several hundred years ago, of course, brought the ancestors of contemporary Ghanaians across the Atlantic Ocean to serve as slaves. And so as African Americans, we have quite a bit of shared ancestry with contemporary Ghanaians, but the slave trade for East Africa was largely brought eastward. And so we don't have, as African Americans, as much shared ancestry with contemporary East Africans, including contemporary Ethiopians. So we've been studying the genetics specifically of Western Sub-Saharan African ancestry and trying to understand some of the genetic causes of triple negative breast cancer. So work that has been done by our group and other groups is also looking at the genetic admixture of the Latino American populations, and in particular looking at the European, Indigenous American, and African mixture of Latinx individuals. A fascinating study was published several years ago looking at breast cancer patients in Brazil and found that these triple negative breast cancers were significantly more common in areas of Brazil where the women had more African ancestry, and these triple negative breast cancers were less common in areas of Brazil where the women had more European ancestry. And in other studies that have been conducted by my colleague Laura Feherman et al., they've actually identified the fact that extent of Indigenous American ancestry in Latinx individuals was associated with a lower likelihood of getting breast cancer. In contrast, extent of European ancestry in Latinx women was associated with a higher likelihood of being diagnosed with breast cancer. But again, we have to come back to screening mammography and early detection, because no matter what a woman's background is, as shown by these bar graphs, if you catch a breast cancer at early stage, that woman is more likely to have a better survival rate. And I'm just going to close by going through a few common questions that we hear in the clinic. One, does the presence or absence of breast pain indicate the presence or absence of cancer? And in general, the answer to this question is that no, pain in and of itself is not a feature that indicates the presence versus the absence of cancer. However, if you do notice some new symptom, including pain, it's very appropriate to talk to your healthcare provider and make sure that your breasts are adequately worked up. Should I get a mammogram more frequently if I have a family history of breast cancer? Possibly. If there are multiple relatives that have breast cancer at a younger age, then you may well want to get your mammogram at 5 to 10 years younger than the earliest age of breast cancer diagnosis in your family. Many women will ask if exposure to air via some type of a biopsy will make a tumor spread. And this awful myth is the cause of so much unnecessary pain, suffering, and death from breast cancer. Absolutely not. A tumor biopsy will not make that cancer spread. The worst thing to make a cancer spread is going to be lack of treatment and a delay in diagnosis. Does stress cause cancer? Well, we do need to perform more research to address this question, because it is entirely possible that some of the blood chemicals that circulate as part of our stress response can be associated with the cancer development. Can I avoid breast cancer by following a special diet? You can lower breast cancer risk by following a healthy, balanced diet, but unfortunately, we don't have an absolute guarantee or a magic diet that will guarantee against the development of breast cancer. Is there any way to prevent breast cancer? There are lifestyle patterns that we discussed: healthy, non-sedentary lifestyle, nursing and lactation. Some women can pursue medication to lower breast cancer risk. And then lastly, many women continue to ask me if a brassiere will cause breast cancer. And the answer to this question is absolutely not. And I will stop there, but I do thank everybody for their time and attention.
Drotman again. We have some time for questions. So if anyone has any questions, feel free to either write them in the chat or raise your hand or call them out, or whatever works best for you. Just how you do have about 10 more minutes left. Oh, and Jesse just said there are claps on their end, so thank you.
Thank you so much for coming here today. Both Dr. Newman and Dr. Drotman provided a lot of information, but if you have any questions, please let us know so that they can answer it at this time. Dígame.
I want to know if some breast, some brasieres causan cáncer.
So, la doctora, so we have someone here, she asked if bras have cancer, and I was just gonna let her know that no, the answer is no. La doctora contestó esa pregunta, que no, los brasieres no causan cáncer.
Thank you.
Okay. ¿Tienen más preguntas? Yes.
Mi mamá tenía cáncer y la hermana mía. Does that mean that I'm going to get it?
Bueno, gentleman here who said that his mother had breast cancer and his sister, and he wants to know if he's able to get breast cancer as well.
Well, you know, I got my breast.
I'm sorry, I don't know about Michelle, but I'm not able to hear very
Yeah,
well.
Jesse, do you think you could repeat the questions back to us?
So we have a
I can't really hear.
Can you hear me now? Can you hear me now?
Yes.
Can you hear me now?
Yeah.
So we have a gentleman here who says that his mother and his sister had breast cancer. Does that mean that he may be able to get breast cancer?
It would be very important for either your mother or your sister to undergo genetic testing. And if one of them has a mutation in the BRCA1 or BRCA2 genes, then yes, that would indicate a higher risk of breast cancer for you as a male.
¿Entendieron? Bueno, ella está diciendo que si entonces su mamá y su hermana tendrá que hacerse un examen genético para determinar si él también puede tener cáncer en las mamas. Los hombres sí le dan cáncer en las mamas. Puede tener dolor, puede tener una pelota, y en ese caso debe de ir a examinarse pronto, lo más pronto posible. You're welcome.
And if they do not get genetic testing, please do make sure that you and the other men in the family check yourselves for new lumps or any other problems in your breast.
Okay. Está sugiriendo que chequeen mensualmente para pelotas o dolor o descargo. Okay. Any more questions?
Los desodorantes.
Okay.
I do see a couple of questions in the chat box.
Yeah, I see a question in the chat box. What about young women 30 years or younger being diagnosed with cancer?
Yeah, even though breast cancer likelihood increases as we get older, we absolutely do see breast cancer even in very young women. So if you do develop a danger sign, please get it checked out regardless of how young you are. New lump, bloody nipple discharge, change in the appearance of the breast, please get that checked out.
Preguntaron si es posible si jóvenes le pueden dar cáncer de la mama. Y la doctora contestó que sí es posible, especialmente si corre la familia y si ella tiene síntomas que indican que algo no es normal. En ese evento se debe de chequear, hacerse un examen genético para determinar si ella lo tiene. Entonces, luego hacer los pasos necesarios para no tener un tratamiento tan agresivo.
We have someone here who asked if deodorants cause breast cancer.
Great question. Deodorants do not cause breast cancer. As Dr. Drotman mentioned, we do recommend that women not use deodorants when they get their mammograms performed, but that's more related to the calcification that they can cause. But I'll let Michelle speak more about deodorants and breast imaging.
El
Yeah.
desodorante no causa cáncer.
Yeah, deodorant is fine, but sometimes if you wear it the day of your mammogram, it can look like an artifact on the film, and then we have to repeat the picture. But it doesn't cause breast cancer, and it is not related to breast cancer.
El desodorante no causa cáncer y es importante el día de la mamografía no usar el desodorante porque puedo empañar los vegetales para que no se vean los también. Yes.
Nosotros lo que se me debe ofrecer, no hay un tiempo que uno pare de no hacerse mamografía, vamos a hacer toda la vida.
So we have someone here. She says that the majority, because this is a senior center, the majority of the women here are of age, and they want to know, is there a cutoff age to no longer have mammograms?
So in the clinic side, we typically say that women should continue getting their mammograms until they reach an age where either they have so many medical problems that they wouldn't be able to tolerate treatment if a breast cancer was diagnosed, or an age where their healthcare provider thinks that they probably are not going to see another 5 years of life.
Todo depende de su doctor que determine, a acuerdo de su salud, si se debe seguir haciendo el examen de mamografía, pero sí debe de estar haciendo anualmente su examen para detectar cualquier tumor canceroso o maligno. Any more questions? Any more questions? ¿Hay más preguntas? ¿Usted tiene una pregunta? ¿Cómo? No. Okay. So no more questions on this end.
Thank you.
And thanks, everybody.
Thank you all so much.